Hello, and thank you for joining me on my presentation on oral iron supplementation, its effects and tolerability in patients with inflammatory bowel disease. So today I'd like to assess oral iron supplementation and its effects and tolerability in patients with inflammatory bowel disease. I'll take you through an introduction. So what is inflammatory bowel disease and the related iron deficiency anemia that comes along with it. I will show you my research question, the methodology I used to go ahead and determine my research papers that I chose, the research findings from those papers, and then I will provide a synthesis of results as well as conclusions and an evidence grade from the papers that I selected. I will review their strengths and limitations, the implications of the findings for future research and for clinical practices, and then show you my references. So a little bit about inflammatory bowel disease and iron deficiency anemia, the causes and the therapies. So IBD is a chronic inflammation of the gut that also can have blood loss in the inflamed gut mucosa. This causes impaired uptake of iron and is common in patients with Crohn's disease and ulcerative colitis. Some common therapies include ferrous or ferric oral iron supplementations and or IV administered ferrous or ferric oral iron to help patients relieve the symptoms and the etiology of the iron deficiency anemia. So my research question was, among adults older than 18 with diagnosed inflammatory bowel disease, what is the effect of daily oral iron supplementation versus a placebo or no intervention on the circulating iron levels as measured by circulating serum ferritin, transferrin, transferrin saturation, and CRP levels over a 3-month time frame? When I was looking at my search and selection strategy, I used an inclusion and exclusion criteria through the online search databases at UNE, PubMed, SynHall, Microsoft ARP, or PLOS ONE. For the inclusion criteria, the studies all had to have been performed between 2013 and 2019 and must have included at least 20 patients that had the existing inflammatory bowel disease and related conditions, including ulcerative colitis and Crohn's disease with iron deficiency anemia. They had to have a minimum of 3 months on actual supplementation intervention using a common chelated iron supplement, so your ferrous or ferric iron salts. Some of the exclusion criteria is they could not be patients in a hospital for short-term or long-term health care. They could not have a pre-existing condition or be on medications that could influence or cause iron deficiency, or the conditions that could cause complications with absorption rates of the oral iron supplements other than the pre-existing condition of IBD and the IBD related issues. Also, the study dropout rate could not be higher than 20% during the entirety of the study. So I started with my Prisma flow diagram. I input my mesh and non-mesh terms. I identified about 1,426 studies through my database searches. Once duplicates were removed from all the different search engines, I ended up with 61 studies. Of those screened, I excluded 53. Now, the full text articles that were assessed for eligibility, out of the 8 that were left, I selected 4. The 4 I did not select had some that compared oral to IV iron treatments. There was 2 of those. 1 did not meet the length requirement for time on oral iron therapy. And then 1 included the use of other supplements or minerals with the oral iron dosages that would affect the absorption rates. So with my search and selection strategy. I ended up choosing 4. The first one was safety and efficacy of sucrosomal iron in inflammatory bowel disease patients with iron deficiency anemia. The second one that I chose was ferric mannitol is effective in correcting iron deficiency anemia in patients with inflammatory bowel disease, results from a phase 3 clinical trial program. The third one was ferric mannitol therapy for iron deficiency anemia in patients with inflammatory bowel disease, long-term extension data from a phase 3 study. And then the last one was real-world tolerability and efficacy for oral ferric mannitol in IBD-associated anemia. So when we look at our first study, the safety and efficacy of sucrosomal iron in inflammatory bowel disease patients with iron deficiency anemia, we see that a body published this in 2018. It was an open-label prospective monocentric one-arm study. It treated a total of 30 patients. They were diagnosed with inactive to moderately active IBD and a prior diagnosis of ulcerative colitis or Crohn's disease, and were, of course, 18 or older. They were treated with oral sucrosomal iron in dosages of 30 milligrams per day for 12 weeks, and treatment compliance and adverse events were evaluated every 4 weeks. So during the study, we see that 80% of the patients took 90% of the prescribed regimen, and only 11 gastrointestinal events were recorded in 9 patients during the course of treatment. The results showed an improvement in all blood iron parameters that were tested for, and the results showed a HB increase in 86% of the patients, which means it went up from an average of 11.67 to 12.37 grams per deciliter, and it included a significant increase in serum hepcidin in almost 80% of the patients. Both Crohn's disease and ulcerative colitis patients also became positively correlated with C-reactive protein scores. So when we look at the chart on the right, we can see our HB levels went up, serum iron went up significantly, TSAT, serum ferritin all showed marked improvements, and then down almost to the bottom, that CRP showed almost no change whatsoever, which means that the sucrosomal iron was not causing any inflammation, internal inflammation during the course of treatment, which of course is something we're looking for. The next study that we looked at was ferric mannitol is effective in correcting iron deficiency anemia in patients with inflammatory bowel disease, results from a phase 3 clinical trial program. Gash published this in 2015. This was a 12-week randomized, double-blind, placebo-controlled, multi-center study done in Europe. 128 patients received a randomized therapy. Specifically, 64 received ferric mannitol in 60 milligram a day dosages. They did it 30 milligrams BID, which is twice a day, and 64 received a placebo. The phase 3 clinical trial program evaluated patients with a confirmed diagnosis of either ulcerative colitis or Crohn's disease, and they had to be 18 years old or older. When we look at the results, 55 ferric mannitol patients, almost 86%, and 53 placebo clients, 83%, completed the trial, with the safety profile of ferric mannitol being compared comparable with that of the placebo, and it showed no impact on IBD severity. Again, another the key marker we were looking for. The treatment group showed significant improvements in their HB levels versus the placebo at 4 weeks, 8 weeks, and 12-week testings. The patient showed an overall increase of 2.28 grams per deciliter in the treatment group, as well as an increase in serum ferritin at 28.3 micrograms per liter in the ferric mannitol treated patients compared with a level of 7.85 micrograms per liter in the placebo group. When we look at our charts from this study, we can see the absolute HB steadily increased in all 4-week testing periods, starting off just at 11 grams per deciliter, moving itself up to almost 13 grams per deciliter. And then on the right, we see the response endpoints basically were way up versus those patients on the placebo in all tested patients. So, third paper that we are going to look at is ferric mannitol therapy for iron deficiency anemia in patients with inflammatory bowel disease, a long-term extension data from a phase 3 study. This was published by Schmidt in 2016. This study piggybacked off of the GASH study using 111 rollover patients that had completed the 12-week ferric mannitol trial. This was an open label extension followed up by a 14-day safety period just to check to make sure that the patients did not have any flare-ups or any issues transitioning off of or continuing the oral iron therapy. The patients that received the placebo during the previous 12-week trial were switched to receive treatment with ferric mannitol in the 30 milligrams twice a day for the continuation of the 52-week period. In the previous treatment group, participants that were on the ferric mannitol from the previous 12-week trial continued on with their prescribed treatment for the remaining period of this 52-week trial. The long-term assessments of both efficacy and safety were based on an integrated data set that included patients with ulcerative or Crohn's disease. The results showed normal and sustained hemoglobin levels in over 80% of the patients from week 8 to 52, starting at week 8 due to the placebo patients getting their iron levels up to sustainable and clinically relevant levels. The long-term ferric mannitol treatment also showed a concomitant increase in iron storage parameters for over 80% of the completing participants. Adverse events considered related to the ferric mannitol treatment were recorded in only 27 out of 111 patients, with 8 discontinuations due to adverse events related to ulcerative colitis or their Crohn's disease. Again, when we look at the data in the graphs, we can see on the left that the weeks on active treatment with ferric mannitol, we get a steady increase in the patient's levels, and they level off and stay level throughout all 52 weeks throughout the study. And again, the HB concentrations on the graph on the right, with all the patients, including the ones that were switched from placebo over to the oral iron therapy, had increasing and then steady blood iron levels throughout the course of treatment. Our next one is real-world tolerability and efficacy on oral ferric mannitol in IBD-associated anemia. This was Apong and his group. They published this in 2018. This was a randomized placebo-controlled study. There were 28 patients in the treatment group. There was 16 with ulcerative colitis and 12 with Crohn's disease. The treatment period was 12 weeks long. The patients were given 30 milligrams a day of a brand named Ferricru, which is the oral ferric mannitol, throughout the study, with 3 stopping the treatment due to ongoing IBD symptoms that were unrelated to the Ferricru that was prescribed. So the test results showed the pretreatment median baseline of the participants, their baseline HB was 110 grams per deciliter, and their ferritin levels were at 14 micrograms per liter. The median post-ferrocru HB was 122 grams per deciliter, and the ferritin went up to 28 micrograms per liter. So this was basically an HB increase in 16 out of the 20 patients, with a median increment of about 14 grams per deciliter. The HB fell in 4 out of 20, and the median fall was about 17.5. So that was a little bit more significant on the median fall, even though it was on only about 15% of the treatment patients. The ferrocru was well tolerated in 67% of all patients treated. In addition to that, what is significant is 50% of the patients who were intolerant of conventional oral iron preparations in the treatment group tolerated ferrocru with no complications. So those people that were unable to tolerate other ferric or ferrous iron salts were able to tolerate this quite a bit better. So when we look at the synthesis of the results across all of these studies, what do we really see? We see that common in all 4 studies was the daily oral iron supplementation between 30 to 60 milligrams a day for 3 to 12 months was given, and it resulted in significant increases in circulating blood iron marker levels, right? We also saw positive client experiences in all 4 studies. So the daily oral iron supplementation was well tolerated in both our ulcerative colitis and Crohn's disease patients, and there was over an 80% patient completion rate for all of these studies. The last thing, and one of the biggest things, is there was consistent results in all 4 studies. Right? We had a daily oral iron supplementation regimen between 30 to 60 milligrams a day for 3 months, and this showed increased blood ferritin, transferrin, and HB levels in significant ranges, and it provided a cost-effective and easily accessible treatment for anemic IBD patients. So the overall conclusions and the evidence grade for the studies that were selected, all studies showed an increase in circulating iron levels and markers during the testing. All studies gave daily dosage ranges from 30 to 60 milligrams, so they were consistent. All studies showed a high level of tolerability and compliance from treatment groups and had no reported severe side effects or conflicts of interest within the study time frame. So I gave basically the evidence grade of strong for these studies. One, they showed consistency in their inclusion and exclusion criteria, and consistency in the testing and dosage ranges. Their study design was strong across the board in all of them, with high completion rates. The importance of the study outcomes was significant because of the study population that they used. And then lastly, the population of interest was actually directly tested in these studies. So the applicability of these results can be shown in the patients directly. So basically, oral iron therapy for patients with IBD is an effective modality of treatment for increasing blood iron levels and helping ameliorate the symptoms and conditions of iron deficiency anemia. The strengths and limitations of these studies. First, the strengths showed consistent findings of increased circulating iron in blood markers. The studies were conducted in multiple countries with different populations. They used common and available iron supplements during their studies, and the treatment was on patients that had similar inclusion and exclusion criteria, as mentioned before. Some of the limitations was that 3 out of the 4 studies only met the minimum time frame, so having longer testing periods would have been more beneficial. They were relatively small sample sizes. Larger populations would have given more accurate data and helped correct for any anomalies or bias in the data. And one was a continuation study, while the other three were basically pilot studies. And so there was not a lot of, again, long-term data besides that one in the study sample. There are a few gaps as well, as none of them mentioned any dietary control for external sources of heme and non-heme iron, and there was no testing for external or internal absorption barriers due to diet or other comorbidities, such as other medications or anything mentioned in the studies. So those were some of the deficiencies that can be looked at in the future. So, implications for research. What does this mean for research? Well, first, I'd like to ask the question, are daily dosages of iron supplements between 30 and 60 milligrams a day optimal for increasing blood iron levels and tolerability, right? Is this a range that can be changed? And can ferrous or ferric oral iron supplements be combined with other compounds to increase absorption rates during flare-ups? One of the things that we saw was that we had some people report events during the testing that were related to the oral iron supplements. And is there something that can be combined with these that can still provide effective therapy for the anemia, and also give the patients an option to take that during flare-ups? And then lastly, really, what are the lower limit and upper limit dosages that would be considered effective for treating iron deficiency anemia? These studies use 30 to 60 milligrams a day, but what is the lowest level that would still give us good increases in those circulating HB, ferritin, transferrin, and serum concentrations? And then what is the upper limit to where it is no longer doing any good and may be doing harm through causing flare-ups, absorption issues, and gut issues? Now, implications for practice. I found some positive implications. First, the studies all reported high levels of gastrointestinal tolerability for all participating subjects at the dosages given. So as a practitioner, you can have confidence that in these dosages there is a high likeliability that your clients are, one, going to see the benefits of the oral iron supplements, and two, they're going to they're not likely to have an adverse event. The other thing is that studies were conducted on different populations in different geographical regions, so that shows that the oral iron supplements as a treatment is not limited to specific genders or races, which is great because it's applicable all around the world. And then third, oral iron therapy in these novel iron supplements is and can be a cost-effective therapy for patients, which can help increase patient compliance when they are asked to take the daily prescribed dosages. Thank you for joining me for my presentation. Have a great day.